It's a great pleasure. I see a lot of very familiar faces here, and it's a great pleasure to talk today. So it is kind of a little bit overwhelming, I have to say, after Anna's amazing talk. Thank you for this wonderful introduction, all the history. Some of it I knew, some of it I didn't. So that was actually very helpful to me. What I would like to focus today really is on, we know we're in crisis, but I want to focus on solutions. I'm a very positive person. I'm very, so like we need to get through, we need to get there, how we get there. Um, Now, I was talking to Andy just now, and I was like, um, I was just named as executive vice chair for recruitment, basically. And why do I do that? Because I've been doing this for the last 3 years, and I have my own strategies. And it is a kind of a funny example because it's, yes, I'm at Harvard institution, but we're kind of underdog in the Boston environment because it's very hard to recruit against MGH and Brigham and all the other private practice in the area. So we had to come out with our own strategies. And so being kind of finding those strategies and new solutions, even though situation is dire, um, that's what I would like to talk about today. Okay, so yes, we all know the challenge. We have too much work and not enough radiologists. Um, why? Why is it happening? Multiple reasons. The work is increasing because our population is growing. Our patients are older and going to get older and older, and more patients are being scanned as they're getting older. Defensive medicine is some component of that, and we have APP pandemic, I would say, and they certainly order much more imaging, and that's yes. Okay. All right. I'm short. Sure. Okay. Um, they order more imaging, and they will be more of them. Okay, and that's the fact, and that's not something we can fight, and we just need to acknowledge that fact. On the workforce side, we have limited residency positions. We do increase them a little bit each time, and I'm very grateful to ACR trying to work through and trying to get more and more positions, but that's extremely hard and it's very, very limited. There's a huge shift to part-time during COVID, which continued on partial part-time, slight part-time, work-life balance among the younger physicians. Um, and as Anna said, most of the jobs, and I don't know if any of you part of this community on Facebook, academic radiologists, um, most of the jobs that advertise right now is 1 in 3, or some of them 1 in 4. So right their workload, that how amount of work that those radiologists produce is half to third of what they're used to be doing, right? Um, the other part that I haven't mentioned, one component that we need to say is that we have more women in radiology workforce and in physician workforce, and that's wonderful and it's very much appreciated. But we all know that more women do work part-time than men. That's a fact. And that also reduces the amount of workforce that is available. Those things are happening, and those just facts that we just need to plan for. Early retirements, again, due to COVID and due other things. And again, the retirements are from multiple reasons. So all of this is basically this mismatch that we talked about. Now, interestingly enough, we're not alone, right? And I always like to use other areas to learn for what other people are doing that is in the similar crisis. So anesthesia example, right? And anesthesia is slightly ahead of us in this. And what they've been dealing with for many years now is that they had yearly increase in surgical volume, and they have to be there for that surgical volume, population growth, elderly growth, and all of those things. Their workforce is aging and retiring. And then again, insufficient residency spots sounds familiar, right? Um, so what is their solutions? And this was just one of the articles asking uh, leaders of anesthesia along nationally, what is their solution? Basically, they said that our traditional ratio and workflow is not sustainable, full stop, and we need different solutions. And they have been implementing those solutions. We all heard about CRNAs, NAAs, and what are those CRNAs? And you know what? I looked into it a little bit, and I don't understand why there are no more CRNAs. You do 2 years of training after your BA, you get 200K salary, okay, just to kind of set it up there, some of them more than that, and they don't need supervision in many states, okay? Like magic. Like why do you need this physician career of so many years and so many difficult, hours, etc., when you can be a CRNA? AAs, which is anesthesiologist assistant, similar to your training after BA, slightly lower salary, and they need to be supervised. Anesthesia heavily relies on CRNAs and AAs. I probably would say I don't know of any places that don't use that and just use the anesthesiologist. They also using technology, and for sure they will be using AI. And I'm saying technology and AI is not exactly the same, but it's under the same bucket. And they're in the same thing. It will not replace anesthesiologists. We'll still need people, but it will make our life much easier and much more efficient. And so that delta that we need is going to come with that. And then they're also talking about flexible work and thinking about anesthesiologists, how they can be flexible. Well, they can do all the pre-op visits and post-op visits and things like that. They can do flexibly. And so this is a huge advocate for that, right? So the solutions are all very similar, right? We need to find technology, right? Technology that will help us, flexibility to keep the people who are already in the workforce happy so that they stay, and some sort of adjunct help, right? How are we going to do that in radiology? That's a very good question, right? And so specifically solutions. Our work is increasing, so can we use imaging appropriateness to reduce the amount of work? And I'll touch a little bit about that. Turf reform, I'm not going to talk about that, but that's, potential, maybe. It requires much bigger people than me. And I will talk specifically what we can do locally on the workforce side. What are the quick fixes that you can do today? APPs, question mark, for some of you, IMGs, and potentially technology. Okay, so can we reduce the amount of work? And this is your survey that you did, guys. Thank you very much for giving me this data because it was very interesting. And this is the answer to the question where the unnecessary studies are coming from, right? We all know we have those, strange studies. And interestingly enough, most of them are coming from APPs, and this is from the colors are from rarely to very frequently. That's the scale. And so the purple is very frequently. And you can see that this spiking thing is among ED APPs or primary care APPs. If you have among physicians, you also have inappropriate studies, but it's less so. So obviously, with more knowledge, with more, you're getting less inappropriate studies. So how do you work with that? So can we increase imaging appropriateness? And ACR has done tremendous amount of work on this, tremendous. In 1993, ACR introduced appropriateness use criteria, 247 topics, 4,000 clinical scenarios. 214, CMS introduced clinical decision support requirement for CT, MR, PET, and NUCs, and we all celebrated and said, here we go. Now everything is going to be appropriate, and we're going to solve the problem of inappropriate studies. We are, yes, I agree. 2020, the testing period started. Unfortunately, in 2024, it was put on hold due to implementation hurdles and kind of on indefinite hold at this point. Now, what about the evidence? Is imaging appropriateness, can it be improved through utilization of the clinical decision support through appropriate use criteria? Well, so first of all, that's the response kind of from the community to canceling this requirement of clinical decision support. And this was called as basically burden because it increases administrative hassles tremendously to the referring providers. And this is something that we need to be acutely aware and thoughtful when we're trying to introduce something, right? We want to increase imaging appropriateness, but if it's extremely hard to our referring physicians, they're not going to use it. They're going to be unhappy, and it's if anything, it's going to increase cost to the medicine, to the healthcare. And we should be very careful about that. So what about the data? Is clinical decision support decreases the amount of work? So this is a study from the Kaiser in Colorado. They found that there was increase in appropriate orders after clinical decision support from 77 to 80%. However, there was no change in orders for advanced imaging. Okay, that did not move at all. Another study from Wisconsin. This was actually an interesting study because the setting was the data came from this Aurora Healthcare in Wisconsin, which is a large system in Wisconsin, but it was analyzed by MIT Sloan group, MIT Sloan Business Management Group. And what they saw is the clinical decision support decreased the targeted exam, specifically targeted exam by 6%, which you could argue that this is helpful. However, when they looked overall, the number of high cost and low cost exams did not change at all. Okay, so what is happening, right? So when we're trying to measure something, it's going to improve. But what is the other impact of that? And I was fortunate enough to talk to one of the authors one of the authors from the MIT just at the dinner party, and she was very excited to hear that I'm a radiologist. And it's like I'm getting all this data, and it's so exciting to see maybe we can solve this inappropriate imaging. But what I'm seeing is that the only thing that the clinical decision support does is teaching the referring provider how to order what they want. Okay, so okay, this indication is not going to work, but this will work, so let's do that. And what we're getting is actually wrong indications, so which is less helpful to us than what we had before when it was inappropriate. So not really working as it is. This is another study just came out in JAMA 2025. And interestingly enough, right, all those studies were in states. This is European study, exactly the same results. No change in inappropriate imaging request after clinical decision support was implemented. So you cannot talk about cultural issues. This is just physicians. They want to order and they want to get what they want. And we should just honestly honor that. Because they see the patient. Now, when you get into APP world versus physicians, that's a little bit different, in my opinion, personally, because APPs have very limited training and they're really good in following algorithms. They're really good in that. And so what we need to provide them very clear algorithm what to do. But the fact that they're ordering many more studies is probably because they're very good in following algorithms. Okay, and so when we know our physicians, our referring physicians, have their, thoughtful process and saying, okay, yes, sure, algorithm is asking me to do X, Y, and Z, but I know I really don't need that, right? And so they're ordering less than they were supposed to. Okay, so this is a little bit on the side. I don't think personally we can decrease the amount of imaging. I think the imaging is going to increase continuously. Some of it we feel is inappropriate. I do think that a lot of the inappropriate imaging is actually appropriate, but we're just not getting enough information. And maybe, hopefully, AI will be able to give us proper kind of just out of the epic of all the patient information. And so we can actually give appropriate results in appropriate report to what we read, and not just, mistyped whatever they think, apt pain or, something like that, that they put in a lot of time in the indication. That's I would like, right? Because then we can actually give them the answers that they need. Okay, quick solutions or patches of what you can do in the current system. Struggling. We're all struggling. We all, a couple of years ago, I asked who is hiring, and I was surprised to see that pretty much everybody, and everybody's hiring. Yes, exactly. It's so bad that in the recent meeting that I went to as a section chief and responsible for recruitment, I didn't even in the apps, you can now put, we are hiring for this and this position. I don't even put there because I know everybody's hiring, and anybody who's looking for a job will just come to me and say, hey, what do you have? So I think everybody's hiring. There is no such thing not hiring. Um, so what can you do right now? What you can do today? So internal moonlighting. We started this personally in our institution a couple of years ago. It's working okay, I would say. It's helpful. When you have big enough group, you can always find people who are a little bit thirsty for money, a little bit, wanting to get, that vacation, or, in my case, two kids in college. But it's you need a lot of, you're leveraging goodwill, and you need to remember that. You need to compensate appropriately, and not just, the bare minimum. Those people do need home workstations because I do believe staying at work for extra hours is going to reduce dramatically what people are willing to do. Um, Define clearly the work for moonlighting, because you need to make sure that the productivity during the day stays. We are very strict in not allowing to moonlight during the work hours, and we do audit that, and that's the understanding. But documentation needs to be very easy, okay? And whatever, there are different methods to document what you have done. We prefer paper study because I believe, you wake up before kids on Saturday morning or whatever it is, or after kids went to sleep or whatever it is, you do a couple of studies, that helps. Okay. If you're required to sign on shifts or pay per hour, there's a lot of issues with that productivity, and much less people are willing to do that. Um, we do this at will, and I do, rely a lot on my charm to, at some point, saying, okay, we're really crushing today, but I will not overuse that. People will do it as they want. They know when there is a certain threshold. I don't inundate them with emails, please do, please do. No, they know it's available. They can do it. And when it's really bad, then I will send an email, and then people do sign. More people do that. Uh, that's the goal. Make it easy, because we're really asking people to do extra work. Yes, we're paying for them well for this, but it needs to be easy, and so that actually the work will get done. Um, I do believe that internal moonlighting is great for junior faculty. As Anna was saying, um, that's actually a big problem. Our new, our graduating residents and new faculty, very frequently, their volumes are very low, okay, for a variety of reasons, but we don't prepare them properly, um, not even for private practice job, for academic jobs of this day. The volumes are very high, it's very demanding, and we're really trying to cuddle them and cuddle them, and all our residents, and really trying to support them, but we're doing them huge disservice. They're not able to take the volume, they're not able to take the stress. So the only thing when they have to, in our institution, for example, take the volume is ED shifts, and that's just not enough. And so I do believe we need to kind of get back to them and say, yeah, I get it. You want to read 6 cases a day, but and some of them do. That's what they do. But it's really disservice to you. You're not seeing enough. You're not seeing enough pathology. You're not seeing enough normals to kind of wash your eyes and learn. And you're not getting yourself used to actually do productivity properly. So internal moonlighting actually helps with that, interestingly enough, because they pay per click, so they have incentive to do as much as possible in the short amount of time that they want to allocate to this, and they're gaining speed. They're gaining speed through this, um, and so it's very helpful to them. It's certainly cheaper for the department to utilize internal moonlighting than getting locums, right? Don't have to tell you guys how much locums costs. Are horrible. Um, but it's important in that manner that you should be compensating people appropriately for what they do. Be careful of burnout, because it's more work, okay, and more hours that people work, and you have to be very careful not to request this, at least. And the other functions might or will, I would say, degrade. And that will involve, teaching, administrative, and research. Okay. They're only 24 hours a day and 7 days a week. And we know that most of my papers are written on the weekends, and I'm thinking about them when I have free time. And if I'm doing moonlighting, I have less free time, right? It's just a matter of time. So, not ideal, but as a quick fix, definitely works. Um, you know, I put it this there, should be a temporary solution. We know everything temporarily is the always is remains permanent for quite a while, but I'm hopeful. I am hopeful that eventually we will need less and less of that. External lighting, right? You can reach out, and I was so happy that we opened up external lighting. We were able to recruit people and hire them remotely. I know it's less of many of your institutions already doing that very successfully. For us in Massachusetts, it was a huge hurdle, but we are now doing this. How do you find them? Okay, how do you find those people that will moonlight for you? And I would say the best solution for us is our former trainees or former colleagues that moved somewhere else, and they still like us and they know our systems. They want to work for us. Retirees, right? You can try to bring them back even remotely, and that works pretty well. Teleradiology company, I've heard quite a bit recently now of academic and I'm still kind of struggling with the idea, but there are apparently academic radiologists that are looking for more work. I don't know where they are from, but they go into those teleradiology companies and they work for other academic institutions. That solution exists. Um, we haven't tried that personally, but apparently it exists, and it's not just VRED and other companies. Okay, flexibility. Flexibility is a huge thing, especially, and you know what? It's great for younger generation, but it's great for everyone. I love my days, one day from home that I sometimes do. I love and hate it because it's actually very hard to work from home to be as productive, but people need that. And flexible hours, type of work. Can you do a shift, early hours in the morning and do your thing? My goal for my section, for abdominal section, is to have for everybody at least one day to work from home to be able to give that flexibility. We currently can't because um, I have 3 sites with procedures. We still do procedures at BI. And so I have to have people on site for fluoro and for procedures. But that's the goal. As we hire, as we're able to actually cover our volume properly, we'll have more people at least sometime working from home. Reduces commute time, etc., which is obviously much more important for New York. But it's even small commute is important. Okay, now the downside of work from home, and this is something to remember, there's a huge part of isolation and loneliness, and no connection to your colleagues, and not just colleagues, workplace. Okay, as a result of that, you have zero loyalty. And so a lot of people that now starting to move around, not just that, obviously, the reason, but some of that reason is if you're not connected to your group, there's no reason for you really to stick around apart from the pay, right? And that's a very kind of a easy thing to change. If suddenly somebody else offers you a better job, money wise, you just go around, right? So it's important to make sure that even your colleagues that work from home are connected to your group. Um, it's um, it's hard, right? And teaching remotely, I personally don't like that. It's doable. We did it through COVID, but it's really hard. But that's another way to connect and make sure communication with your techs. Techs are also feeling very lonely, and some of it, if you ask the techs, like we're in the hospital, why my physician cannot be in the hospital, right? And uh, at least what I try to do is when we are on site, I try to also institute it to our residents, go in the morning and say hi to your techs. Okay, you're working with CT techs, they're going to call you every 5 minutes with questions, right? Go and say, hi, my name is this, here's the face, and then use Epic Chat and not phone calls. But anyway, meaning like having that face, having that communication helps both the physician and the techs. So connection, that's very important. Okay, some technology fixes. This is my favorite thing, focus reports. Focus but simple reports, okay? I'm not going to go into details about pancreatic cancer staging report. If anybody is aware, this is fantastic thing that was done a couple of now decades ago, I think. It's extremely long. It's extremely, extremely long. Uh, and this is required by NCCN guidelines and all of those things, but it's only really required for patients who are about to undergo surgery and candidates for surgery. After they underwent treatments, that's actually, you can do much more simplified reports. So having templated reports, but focused reports would be much more helpful. So you need to talk to your referrals to know what exactly they're expecting. Because if they're expecting the full, 48 items templated report for each pancreatic CTA, and you're producing, 5 words, no change, or something like that, then you have a problem. So talk to referrals, but then try to focus to exactly what they want and which stage, and build those templated reports. Yes, it's going to be, will take your time that none of us have, but it's long term is going to produce much better results and will help you a lot. Now, it took me a while, but in my reports, I switched to the whole description, nice description of findings in liver, the texture, normal, okay? Or unremarkable. There is the two school of thoughts here. But that's what the referral physicians are looking for. You can have a little bit more than normal, but really unremarkable is the way to go. Why? Because and then I got the feedback from other radiologists actually is that if you're working with trainees, it's much easier to proofread their reports if the whole thing, the template is just unremarkable. Because if they add something, you can see it very clearly and very fast. So it's simple to dictate, it's simple to review, and if you're following up, if you're reading a follow-up study, it's very easy to identify what was actually written there. It is definitely preferred by referring physicians. So again, who is our client? Our client is referring physicians and patients. And so this unremarkable pathway is definitely a way to go. Talk to your colleagues, talk to your referrals, and then create some sort of consensus reports that is shorter, focused, and will be used by the whole group, right? Because if you are the only person who is using that template report, it's not really going to help you because you're reading follow-up studies after a lot of other people, right? And the consistency is going to be very helpful. We do, in our practice, do allow attendings to create their own templates, but not to the residents. And I think it propagates pretty quickly. After a couple of years, you have very standard reports for the whole department. Okay, we are humans and we make errors. That's normal, that's expected, okay? So what we need to do is to reduce the ability to make errors. And one thing is to auto-populate your reports. And I just as a word, how many of you have the modeling or basically automatic measurements being transferred into your reports for ultrasound? Very easy solution, been available for a very long time. All your DEXA reports, all your ultrasound reports, radiation dose reporting can be automatically taken from the machine, like ultrasound machine, DEXA machine, etc., and being put into your dictation software. Okay, I didn't we have it for quite a few years. And by the way, those who don't have, your majority, not surprisingly. I just went to another big academic institution, and I was surprised to find that also don't have it, and they all dictate all those numbers. Like, forget about the fact that I don't understand what's our obsession with renal length on ultrasound versus CT, where we don't report it at all, right? But we do report it. That's kind of standard practice. But all of those measurements should be auto-populated, should go automatically. And here's an example, right? So we have so many measurements on ultrasound, right? But we are not right? And so all of those measures should go automatically. You should be looking at the images, looking for pathology, looking for something in texture and things like that. But the measurements, they're already done. There's no reason for you to dictate them. So yeah, so you can use DICOM structure report XML or HL7 measurements data, and you can transfer from all different modalities from the machines and reports being auto-populated. Right, and so when you have, for example, carotid ultrasound, 5,000 measurements, and can you imagine, so you have all those measurements, how many mistakes are you making? At least one in all those measurements when you report them. The big question is what's the impact of that, but that's a separate issue. But yeah, you have 26 fields here. So all of this you can auto-populate very easily, and that's the thing, we are paid for interpretation, not for data entry, right? For data entry, we have machines, we have computers, and we're also bad at that. So, okay, voice cues. I love that. So some dictation software will tell you which field are you on, and that will allow you to keep your eyes on the image versus on your dictation software, right? We have all those 5,000 screens, right? But we really don't want to be looking at your dictation. You want to keep your images as much as possible on the images. Studies shown the more time you spend looking at the images, the more you find, the less you miss. So that's the goal. And that improves your focus as well. Let's see. Here's just an example how it works. Okay, so that's how it works with voice cues. That goes on the side. At the end, I just review the images, review the report, and get it. And our software also shows exactly what I've changed versus what was the template. So that works like that. Now, the future is to have more branching logic, right? All those great recommendations from the ACR, they're all extremely complicated, right? And trying every time, okay, now I have this incidental cyst, pancreatic cyst of this size and this age, what do I do? So this really branching logic, again, computer should be doing this, not us. We're not quite there yet, but obviously it's relatively an easy task to do if one of the companies will take this on. Macros and contacts, the more you do, the more you utilize this specifically for your reports is going to improve your efficiency as well. And you can have all those can test or macros for a variety of recommendations that you dictate routinely. I'm abdominal imager, so a lot of that is here. In the future, hopefully we'll have something that will be even better. For example, for TIRADS, like you put different things and it automatically sums up the points and gives you the TIRADS score. Again, and not in our software, maybe in some others, but it really, again, what computer can do, computer should do. That's that's the goal. So those efficiency reporting tools that I would strongly advocate utilizing, it's not just going to make you more efficient, it will also make you better and the quality will be overall improved. There was a lot of stupid errors that we make and we're getting those phone calls, afterwards from the referring providers, why, endometrial thickness is 15 centimeters. Is it really true? Right? So all of those things really needs to happen automatically. Okay, workforce solutions. Okay, I'm getting to more interesting stuff. right? This is the numbers that I got. So everybody quotes different numbers, but ACR has a lot of jobs. And we have that gap. That gap is been constant for the last couple of years, is about 800 positions. Um, and, you know, from my perspective, somebody who started practicing in the US in 2009, um, I have not really seen those troughs. Okay. What I've seen is huge amount of work, huge demand, and not able to recruit. Okay. And so my view is slightly biased. I know you guys seen big troughs and people not able to find jobs. I'm very positive. I think as much as we can improve in our efficiency and utilize all those tools, we'll still need a lot more people. The work is coming, and the people are aging, and as they're aging, they just utilize more imaging, and you have more APPs, and APPs are more imaging. So this is kind of constant that I don't think there is any way anytime soon it's going to stop. So how do we breach that? Right, AI. Yes, yes, AI. NPs and PAs, and I will talk about what is currently utilized in the market. Increasing number of residents, I really hope so, and IMGs. Okay, so increasing number of residents. Um, just now, there is a bipartisan draft legislation introduced in December that is trying to increase number of residents, 5,000 resident slots, and that's overall. The focus is really on psychiatry and primary care, but ACR supports the bill, and hopefully we'll see some of the radiology resident spots there as well. Now with new what we have on the hill, I don't know what exactly going to happen with that, but that's what we're trying to do. Now, there is a lot of talk, and when you talk to radiologists, is well, why the government needs to get more residency positions? Should we be looking into alternative ways to fund our residency spots? And that's certainly a conversation, whether it's insurance companies that should be supporting more residency slots, or just you as a practice saying, okay, I need more physicians, more faculty afterwards. Why don't I fund more residency slots? It is kind of a slippery slope, because the moment you start doing this, the government will say, well, you can do it yourself. You don't need us anymore. So you definitely don't want to overutilize that. But there are certainly different healthcare systems that started doing this, and in some programs and in some other specialty, they are funding themselves residency positions. So it's not unheard of. It does require long-term planning, which we're not great at. And because it is, 5 years ahead, you need to find those residents and plan what you're going to do with those residents 5 years later or 6 years later, right? So it is, we do need more residents. We do need more physicians. And how do we do that? That's a very good question. I think there are pros and cons to each side of how you do it, but the overall is we do need to do that. AI. I think the goal of AI and the goal of any technology involved should be to minimize the time that we spend on the routine, less complex things, tedious. If Dr. Rosenstein doesn't like screeners, I hate screeners, and I'm asked to read chest CTs, for screens, right? And I can do the chest portion in a couple of minutes, but then I spend 5 more minutes looking for those pulmonary nodules. I don't want to do that. I don't find it interesting. And the computer, I'm sure, can do it much better than me. Okay, right? So we really should be utilizing computers for things that computers can do better. So is it a threat or solution? As of December 24, nice number of 777 FDA cleared algorithm in radiology. Vast majority are actually for image reconstruction, okay? If you look closely into that. And you're already using them, okay? You're using them on the Mars scanner that decreases the time of reconstruction. You're using them with CT. So we are using AI already everywhere. Okay, it's not a question of when, we already do that. Some of it is for workflow and image analysis, but this is really minority of algorithms that are out there. Now, this is again, thank you for your responses. Um, because in my practice, we're still not using any AI for image interpretation, or but you guys do, and this is the spread. However, there's huge amount of research. The implementation is still lacking, right? We do implement this, but it's really hard, and sometimes you have to really watch how well it's implemented, consistency overall. It's hard to push those things together. So a couple of things that has been shown, and I'm specifically trying to be um, very general, because there is not just one product for each of those things, right? There are multiple products for different vendors, and that's great, because eventually they will actually get to the product that it's actually going to work really well. So impression generator, basically ChatGPT-like, but it has been shown that it reduces up to 60 minutes of your time during the day, which is a huge amount of time. If you think about it, that's like 10% of your time. Um, Overall, the approximation is that workforce shortage right now is about 30%, right? So if we can get all those technology solutions for multiple small things that we do, like impression generator, to give us back 30%, then we are okay for now. We still need to recruit, we still need more people, because the volume is going to continue to grow, and APPs are here to stay, right? But at least for now, we will catch up, and we'll be able to teach, we'll be able to maybe write some papers, and we'll be able to innovate, right? Radiologists always been innovators. It's kind of lacking right now. Okay, pulmonary nodules. There is there are many softwares out there for pulmonary nodules. Funny enough, when I was a resident back in Israel, friend of mine was involved in pulmonary nodal software already, and he was selling that software to, I think, GE at that point. And so this is like 20 years ago. This is not news. It's been there, right? The fact that none of us, or not many of us, utilizing it at this point is really unfortunate and disappointing. But it's definitely there, and we need to implement this, and it will help us tremendously. Now, it's not going to be perfect. It's not 100%. This is one of the latest study that just came out. Uh, and that shows that has a uh, very good result. It does produce one false positive per scan, but it did show that sensitivity of radiologists is less than AI, right? So they're overcalling stuff, and you need your eye, your radiologist eye, to understand which one is which, but it helps you to identify them properly. And here's the comparison, and you can see here the circles are radiologists, and the lines is AI, and you can see some of radiologists are worse than AI. Some of them better, but some of them are worse. So AI, if anything, are going to improve your quality, and so using this together is going to be very helpful. And so I'm not touching, on breast, where again, AI, and it has been quite a while there with different results, but AI is going to be helpful. MSK, there are different softwares for detecting bone fractures, for quantitative measurements of scoliosis and limb length. Again, why are we as radiologists need to measure things, right? We're not good at it. So let's computer do its thing. So repetitive measurements, segmentation, calculation of volumes, that's where I see technology in general, or AI, do a thing. Now, implementation is a huge issue, right? A lot of systems are not compatible. You have 5,000 different vendors that come and say, hey, I have the greatest thing, but implementing this into your system is very difficult. So ideally, you should have one platform that somebody else is figuring out and vetting all those systems and making sure that it works, connects well into your recent packs and everything, and fluency and whatever dictation software you're using. but those do exist. They're just very expensive right now. So at this point, a lot of organizations choosing, picking and choosing, right? Okay, I'm going to do, pulmonary nodules, and I will do this, and then I will bring this. It takes a lot of manpower and a lot of time, IT time, and physician time to make sure the implementation and auditing afterwards is done properly. But it's going to work, and it's going to help us. That's that's my point. Okay, APPs. So APPs are slowly going into radiology, slowly, insidiously, but it's certainly happening. IR is using APPs pretty routinely it started for non-procedural evaluation and management, right? We don't have time to go to the floor and consent the patient and work them up, etc. So we hire APP, which is a third of the cost of radiologist, and get the work done. They started doing basic procedures slowly and slowly. Now, not that slowly. Okay, so this is the data that was published in JACR recently. 21% of the peak placement for Medicare patients are done by APPs. Okay, and you know what? That's great. Okay, do you need a radiologist to place a PIC? I don't think so. Okay, paracentesis, thoracentesis, all those, exchanges and things like that, those are routine procedures that are very low risk, very tedious, take a lot of time, and don't pay as much, right? We are, increasingly, a lot of practices are hiring MPPs to do them. And it's certainly to detriment of our residents being able to do that. And you still have to keep this in mind, that you will be able, your resident may go to private practice that will cover that community hospital that cannot hire APP because they don't have sufficient volume. And you need your residents to be able and go and do paracentesis and thora, etc., and not be afraid of needle like most of them are right now. So it's certainly helpful. It's certainly, when you have a large volume, it's going to happen. And I don't, I kind of converted personally from no, we shouldn't be letting them do this at all, to it's helpful. Okay. But you have to be careful in supervision and things like that. The good example of how, like, in my mind, I accepted why APP can do those procedures is, when I was an intern, I was doing IVs. I was taking bloods for the patients. Okay. Now we have phlebotomists who don't have a college degree. We train them in a course, and they do that, and we trust them, and it works fine, right? So certain manual tasks that has very clearly um, defined what's their scope of practice, the training, and then they have supervision, you certainly can delegate to APPs. Now, is liver biopsy routine liver biopsy are going to be done by APPs? As you can see, the numbers are increasing, but they're certainly very low still. It's a high risk procedure. Sonographer practitioners, that's another kind of non-radiologist that helping us to do the work. Basically, those are sonographers that are advanced, that are very knowledgeable with a lot of years of experience, that don't want to scan anymore, okay? Whether it's for MSK reasons like shoulders, etc., but they have the knowledge. And what they do is we hire them to predictate ultrasounds. They work as kind of a trainee, but they're better than trainees. They cannot and should not be independently interpreting the studies, but they're huge help in workflow. Those are relatively common, I would say. I know quite a few practices that do utilize them. Tech assistance, okay, that's a real one, right? Can we allow X-ray techs or APPs or whoever dictate and interpret X-rays, or even predictate X-rays? So I know one practice that does that, and you all know where it is, which faced huge backlash, as all of you know, nationally against them. They have it now for 8 years. Okay, they say it works really well. The quality is great. And they don't interpret independently. All of the studies, all of those X-rays are overread afterwards by a physician, but they already have full report, and they're also helping if something needs to be communicated promptly, to communicate promptly as well. Kind of AI, sounds like it, right? Something that predictates automatically. You just review, and then you overread this afterwards. So I do hope that AI will be there, but it's not quite there for X-rays. I hope, within 5-10 years, it will get there, and we will not need to hire X-ray techs to interpret or help us to interpret X-rays. I do want to bring this here because X-rays, $8 per thing, right? It's really not worth it to hire radiologists to read X-rays, as all of you know, just for the volumes and things like that. It's just not cost effective, but it's certainly an important part of our work, right? And some of them are quite hard to interpret. So I'm still kind of torn on that. I wonder what you guys think about that. But I do want to bring it as, and kind of, CRNA and AAs, right? You remember from anesthesia example. The other alternative, and it's certainly there, is whether we should just not dictate X-rays, especially those MSK X-rays that ortho is looking way before us, and they probably know much more about what the patient is in front of them, and they see them all the time. There are certainly countries that don't dictate X-rays anymore, and those who hire IMGs. That was recently a my issue that we hired somebody, and they're like, "Yeah, we don't read X-rays in the country." I will not name that country, but it's happening in other places because the volume is just overwhelming. And so this is something to consider. Are there at least type of X-ray that you may not necessarily need to interpret because it's your time? And if you're interpreting X-rays, it's you're losing money on that. Just be very clear. Okay, another solution to workforce, and this is something I'm extremely passionate about, is IMGs. All right, so those three people, I don't know if you know them. I'm sure most of you do. What's in common to three of them? In 2023, that was the data in 2023, all three of them were Harvard associate professors, were chiefs of abdominal radiology, fellows of many societies, basically leaders in the field. And 25, just to update you, all of them advanced into more higher leadership roles, but all of them are IMGs, okay? All three of us didn't train in US. So what I want to say, and it's, just want to say it there, our appearances, our accent, our grammar may not be perfect, but it doesn't equate into competence and knowledge and dedication and innovation. So I'm confident that, I look at our residents and they're fantastic. They're the best of the best, Harvard residents, right? And they're great. They did research. They have the knowledge. Their USMLE is fantastic, right? So all of them is great. And all of them will go into middle of nowhere, Nebraska, to read remote from their basement, okay? They're not going to innovate because they have loans that they need to support, right? And I don't blame them, right? I understand that completely. But people who come from other countries, they don't have the loans, and they do still want to. They have that burning passion to innovate and to do things and to change things. I'm not saying Americans are great, and I like every Americans that I'm able to keep in the program. I'm just so happy and very supportive. Okay, so how to sponsor IMG? It's not easy. It's not easy at all, but it's feasible and it's doable. So first, ABR has a lot of, it's just one of the boards in that actually allows this alternate pathway. It doesn't exist in any other specialty, but it does allow internationally trained radiologists to become board certified radiologists in US. What it requires is to be 4 years in the same academic institution. And those 4 years could be anything. It could be part of it could be residency, small part. Fellowships is very common. It could be faculty. It could all 4 years be faculty. ABR does not care. And or it could be 2 years of fellowships and 2 years of faculty, and then 1 year of research. The second part that you need to be aware is the state license. For trainees, there's a limited license, and this is specific for Massachusetts. New York probably has different rules, but faculty can be on full or temporary license. And the temporary license is a special thing for Massachusetts, special clause, which really you can't find until you look for, but it does allow to actually bring internationally trained physicians, advanced faculty, directly as a faculty. But it is state specific, so you really need to know your rules. Hospital privileges, that's another part. You need to make sure that your bylaws are allowing to bring IMGs. And here, I'm sure you as a physician and in your practice can make the difference. Then insurance, okay, that's another hurdle that you need to make sure is that, but most insurances will accept non-board certified radiologists, but not all. And again, state specific, you need to check for that. And then the visa. The visa is really a stickler here. A lot of, unfortunately, IMGs are brought on J1 visa, which is a training visa. That's very easy, very simple, very cheap. But as anything cheap is a bad idea because it basically requires them to go back to the country of origin for 2 years. Okay, so if you bring them for faculty, like you train them as a fellows, you can't keep them for a job in most of the institution unless you can do a waiver. In most academic institutions, most institutions cannot do a waiver. You're better off bringing them on H-1B visa, which is the work visa, which is filed by employer. It costs money, but in the grand scheme of things of hiring future faculty, you're certainly saving huge amount of money by doing this. But it does allow to hire directly into faculty, or after the fellowships, they will be able to stay as a faculty. I would say, and my advice to any IMGs that come to me now that they know that I'm very much a proponent of them and supporter, is do not accept any positions on J1 visa, because you're basically shooting yourself in the foot, and it's very, very difficult afterwards to figure out what you do for a faculty position. So H-1B is the way to go, even though it costs some money. Okay, so many places do alternate pathway, and this is just a little glimpse of institutions that have the alternate pathway at this time, and this is advertised ones, right? BI has alternate pathway. We don't advertise it, but we have it, and so a lot of places do that as well. Now, this is our pipeline. This is graduation from a couple of years ago of our abdominal fellowship. As you can see, we're very international. This was our pipeline a few years back. How did I start with that? Honestly, from necessity. I was recruiting for abdominal fellowship this was 2022 in November, and what I saw is that we interviewed all our applicants. We had plenty, wonderful, and then we filled one position out of 6. And I was like, oh my God, what I'm going to do? So I went on Twitter, at that time, put this one-liner, recruiting for abdominal fellowship. International candidates are welcome. Didn't say anything else beyond that. Within 6 weeks, I filled all the position and plenty, and I had to spare, right? I had plenty of candidates to choose from. It does require commitment to bring them on H-1B visa. So now this is just updated pipeline. At this point, as of February, just check that. We have 35 people in the pipeline, different stages. Some of them already joined faculty. Some of them are scheduled to join faculty this year, and some later on. We do need 35 people because Dana-Farber is joining us, and we need about 30 radiologists to hire. So this is good. We're not over hiring. Don't worry. I'm not going to spare any of them. But yeah, you can do this. There is a great talent out there. Great talent. Now, what about quality? Everybody will ask. Okay, language barriers certainly can be there. And I would say be very careful and thoughtful, but bring those constructive corrections as they need to. Make sure that they follow your standards of reporting, okay? Different countries, different institutions will have different approach to reporting, okay? When I came from Israel, my reports were very brief. It took me a while to learn the way of BI, okay? The level of details and things like that. It doesn't mean that it was less impactful, but at that time, the reporting was very verbose at BI, and I had to learn that. Okay, so that certainly can be learned, and you have to kind of make sure that you teach them and show it to them. Now, training overseas is different, but not necessarily inferior. Okay, and that's something that I want to say. Yes, they may not be reading X-rays, and so this is something that you need to inquire ahead of time, but they may be fantastic in MR or CT or something like that. Certain gaps you need to address, and in just making sure that you know what they are. Different countries, different institutions may have different gaps. I can tell you in Israel, the OB ultrasound is done by gynecologists. And so when I came and had to do pelvic imaging, you saw one of my fellowships on pelvic images, I had no idea what I was doing. Okay. Now this is one of my areas of subspecialty. I absolutely love it. There's no question that those things they can be learned. And you can learn things from your IMGs as well. They have different practices, and I learn every day. So, certain things that you might need to address and keep in mind, their interactions may be in different way, cultural differences, and so just keep in mind and address them as they go. So the key principle for me, and I do kind of go with that with my faculty, respect is very important, right? Those fellows that come with and work with you, they're your future colleagues and faculty, so address them appropriately. But do address things promptly and early so they can be corrected. And the end result is very much worthwhile. We very much enjoy that. Okay, so one last thing that I want to touch on, operations. Okay, so operations is kind of, okay, we talked about our workforce, we talked about, challenges, we talked about how we can decrease the work, but can we be more efficient? And one of the, you know, eventually, even though we're healthcare and now focus on the patients, we're trying to earn some money here, right? To pay more salaries and things like that. And the way to do it is to improve our throughput, one of the ways. One theory, that one kind of management principle that I would like to introduce to you all is theory of constraints. Not very widely popular, though, even though it's been out there for quite a while. This is the book that described that. It's actually a fiction book. It's kind of nice to read, not very dry. It's very interesting to read. But it is provides this basically focuses on your throughput as a kind of a flow, right? And then you have a certain bottlenecks in that flow. And that's where constraints are coming from. And you want to manage those constraints or bottlenecks as much as you can. So throughput in medicine is how we generate our revenue from our services, and in radiology specifically is how many studies we do or procedures we do per day. And focus is here on the patient. So the goal is to maximize our throughput while minimizing our operating expense, right? Not we can't really get another radiologist, another scanner or anything like that, right? We want to, but we need to optimize what we do first. So it is important to kind of look at your bottlenecks, and your bottlenecks specifically in each of your practice, right? We talked about common ones, but specifically in your practice and your workflow will be very special, right? If I look in my procedural workflow, my biggest constraint here is transporters, okay? And that's something that I need to address, right? Or technologist, or the workflow specific step in the technologist workflow that you can address. Or if you're looking at your radiologist workflow, what is the bottleneck is where is the work waiting to be done, right? And that's where you need to address. So right now in our department, the biggest problem is chest CTs, screeners, right? So for screeners, how can I address screeners? I'm really trying to bring on AI to solve, pulmonary nodules issue, right? And so when you because improvement you can do. I love quality improvement. I think it's very important, but you really should try to focus on things that are currently the most important, where the work is stalling in your workflow today, and optimize for that, and then reassess, because if you fix one bottleneck, there will be another one. Um, So in summary, healthcare is in crisis. We know that, and it's not just radiology. However, it's not all doom. There are definitely solutions. We do, and I did provide a review of some short-term fixes, and there are long-term fixes that are also available. And think about constraints in your personal workflow, your technology's workflow, your practice workflow, and try to optimize for that. Thank you. Thank you very much.